Right, good morning, Mr. Poolman.
Good morning.
Good morning, Mr. Gill.
Good morning, my lord.
1 minute, please. I haven't been provided with a notebook. Could you go and ask? Duncan will probably get me one. That's a most unusual mistake, I'm sorry. Thank you very much indeed. Now, my apologies to you both. I'm sorry.
No
Thank you.
My lord, we have 3 witnesses today. They are all office holders of the Royal College of Nursing. And the first of the witnesses is James Colin Poolman, whose witness statement is SCIWT 0497 and then 501. Mr. Poolman, your full name is James Colin Poolman, I think.
That's correct.
And your details are known to the inquiry. You provided a statement in the reference I've just given, and you are content that that statement, as amplified by the evidence you're about to give today, will constitute the material you wish to place before the inquiry?
I am.
You provide this evidence as the director of the RCN Scotland.
I do.
I'll use the abbreviation RCN. I think we all use it. I'm sure you do. And before we go into any detail, this is something that you have provided me with prior notice of. I think there is something you would like to publicly say before you give your evidence to the inquiry.
I would, and I thank you for the opportunity in doing so. I think it's important for myself personally and on behalf of the Royal College of Nursing in Scotland to offer our condolences and our heartfelt thoughts to everyone who's lost loved ones during the pandemic. Of course, we will never forget the sacrifice frontline workers, including those in nursing across health and social care, who passed away as a result of the pandemic, selfless individuals who, in our view, were just trying to do their best for their patients and paid the ultimate sacrifice. We also have many others who contracted COVID in their workplaces, who've gone on to suffer long COVID and continue to experience debilitating effects of illness, and we must ensure we support them as we go forward. Of course, the inquiry will do its job and we will learn from the pandemic, but we all in society owe a debt of gratitude and must never forget the dedication shown by thousands of health and social care workers to their patients and their professions and the impact that the experience has had on them. Thank you for giving me that opportunity.
Thank you. Now, just a few preliminaries, Mr. Poolman. Firstly, your statement is relatively brief, but within it, it's quite detailed. And I do want to make the point that if there are parts of your statement that we don't touch on in the course of your oral evidence today, that does not mean that those parts of the statement are ignored. The whole of your statement, it will be considered and taken account of by the inquiry team, analysed and utilised. So please be assured of that. Secondly, we do have a general restriction order in place which prevents the naming of other people. So I don't think there's a great deal of difficulty having looked at your statement, because the only other people you name are in fact your 2 the two other witnesses who will be giving evidence today, and that's fine, name them. And I think also you may have named some politicians. But so beyond that, please don't name other people you may have had conversations with or something like that. If you do, it doesn't make a great deal of difference. We'll just have to stop proceedings. But if you can just be mindful of that. Now, you're authorised, I understand, to give this evidence about the RCN's views on the impacts of the strategic decisions made by Scottish Government in respect of health and social care. Is that right?
That's correct.
And your colleagues Norman Provan and Eileen McKenna will expand on certain areas, and we'll hear from them later today. But there will inevitably be certain overlap between some of the things that you'll be talking about and things that they may be talking about, but in greater detail.
Indeed.
Some personal information, first of all, if we may. You provide your career history in paragraphs 4 and 5, from which we can see that you took up the post of Director of the RCN in Scotland in September 2021. You took it up initially on an interim basis.
That's correct.
And your appointment was made permanent in September 2022.
That's correct.
So during that period, it obviously coincides with some considerable period of the pandemic. Can you tell us a little about what the post of Director involves?
The post of Director for the Royal College of Nurses in Scotland, first of all, I'm responsible for leading the organisation in Scotland in all aspects of our work in relation to both the representation of our members, whether that be in workplaces or indeed working with other stakeholders such as Scottish Government and working with fellow trade unions and professional organisations. I'm responsible for coordinating that work in Scotland, but also as the Director of the RCN Scotland, I'm a member of the RCN executive team, and I'm involved in the UK workings of the college in relation to my executive responsibilities.
Well, obviously you also do tell us a little about the RCN Scotland, and we can see that it is both a Royal College, having been granted its Royal Charter in 1929, and it's also a special registered trade union.
That's correct.
Your colleagues also give this background, and just for the avoidance of repetition, I'll just take this information from you rather than going through it with other witnesses. Can you tell us a little bit about the membership of your organisation?
Well, the membership's made up, at the time of the pandemic, we were over 40,000 members. It's increased since then. Our members are drawn from the nursing profession. We have 3 categories of membership in Scotland, and that is, we have the category of full members, which are registered nurses, who are on the Nursing Midwifery Council register. We also have those who are nursing support workers, or other terms that are used in relation to that. There are multiple, and we also represent student nurses who are at the start of their careers and going through their education.
And I think, just for the avoidance of any doubt, a nursing support worker is defined by you in the footnote at the bottom of page 3 of your statement.
That's correct.
In paragraph 3 and also paragraph 11, you provide us with a general overview of the burden that your members carried during the pandemic and the impacts that it has had on them, and perhaps reflecting some of the points you made in your initial statement. you say in paragraph 3 that members reacted in extraordinary ways by coming out of retirement, putting aside their studies, and being redeployed to specialised clinical areas.
That's correct. Our members work in all parts of the health and social care system. So that's from hospitals, care homes, general practice in the community and beyond. And the nursing community responded as nurses expect. They respond to whatever is thrown at them, but they were extraordinary in the ways that they did that. And they were and there was much asked of them, and they stood up to what was asked at the time.
Mm-hmm. All right. You make the point that we, and I think you probably mean by that the general public, should not forget the dedication of health and social care workers, and remember that many passed away, and that many continue to be affected physically and mentally by the experience of working through the pandemic. And I think that's reflected in what you said initially.
Yeah, I think it's really important for us never to forget what people gave individually and collectively in their experience. And I think the other important point to just recognise is many of our profession, both individually and collectively, have not had the time to really reflect about the impact on themselves of the pandemic, because they very quickly moved into recovery. And I think it's aspects like this inquiry and other things that have been in the media recently that are actually making people look back to what they experienced and the considerable impact it had on them and their colleagues and their families.
Can I just ask you one point? I think we probably all remember standing on our doorsteps and clapping for you and your fellow workers. How did you feel about that?
I think at the time people were obviously, it was the recognition and the recognition from the public about what our colleagues were doing to basically fight against this horrendous virus and pandemic that we had. And over the period of time, it was truly acknowledged and colleagues felt recognised. And during that time, it went on for some time, if you remember, every week it went on in that, and people were thankful for the appreciation. But ultimately that moved on very quickly, I have to say, once the pandemic was over.
Yes. When you say it moved on very quickly once the pandemic was over, is there an inference in what you say that perhaps it might have been forgotten about?
Well, I think society's moved on, and as I say, we've moved on in relation to, if I talk about health and social care, to deal with the pressures that are within there at the moment. I think we have forgotten about the impact on, as I say, not only society, but the impact on our profession and health and social care itself of the pandemic, because it's been considerable.
Yes. Can I move on to ask you about RCN Direct that you refer to in paragraph 12, and then give some further details in paragraph 13 of your statement. Can you just explain what RCN Direct was and why it was established, if it was established specifically during the pandemic?
It wasn't established because of the pandemic. It was RCN Direct is our contact centre that we have set up for our members to contact us initially on any concerns or any issues that they're seeking advice and guidance on. And it's manned on a daily basis, and our members can contact, as I say, directly, not only through a telephone line, but they can also contact us through email in relation to any queries or questions or looking for guidance that they may have in relation to individual or collective questions that they may have through the experiences they're having within their workplace at that time.
And what you set out at paragraph 13 of your statement is a series of various issues that were raised by your membership during the pandemic through contacting RCN Direct. And I wonder if I can just focus on a few of these, please. Firstly, could I refer to what you say about, well, you mention issues in relation to mental health. You say feeling depressed, anxious, and stressed, and reporting experience indicative of a probable post-traumatic stress disorder. Now, could you give us a little bit more detail about that from your knowledge, if you have it?
Yeah, many of our members would phone to talk through their own personal feelings and experiences of work and the pressures that the pandemic was putting on them in their own mental well-being and in their mental health, and talking around about, the symptoms that we would describe of anxiety, many things that they experience. For example, in the first time in their careers, having to work 12-hour shifts with full PPE, that had an impact on them. Experiencing, I have to say, levels of dealing with death that many colleagues have not experienced had a significant impact on many. And these colleagues would phone for advice and support, and we would try to provide as much as we possibly could in relation to that, as well as the advice and support that we offer from our own organisation, but also signpost to other support that was available.
Yes, well, that was actually going to be my next question. What support do you offer, or do you offer still, I presume?
We continue to offer support to our members for all aspects of their work life and personal life, in fact, when they're experiencing difficulties with either physical or mental health. We provide support within the workplace, as well as we provide, for example, a counselling line that our members can approach for further psychological support if required.
During the pandemic, did you see an increase in the number of your members who were contacting RCN Direct in relation to mental health issues?
Yes, absolutely.
And has that decreased with the cessation of the pandemic?
I think the levels are, because other things are impacting people, so it's difficult to say from the type of issues that come through, because it's not always apparent that somebody's coming through with, ultimately, it's actually their mental health. They come with the situation, and as you talk through with the member, you find out the impact that it's had on them. But yeah, these issues are still, unfortunately, coming through on a much too regular basis with the pressures that they're under within their workplace and their own lives, of course.
Yes. And I think you give a little bit more information about this at paragraph 27 of your statement. And I think we can see there that you say that over 50% of your members responded to a 2020 survey, said they were worried about their mental health.
We routinely survey our membership on many things, but in 2020 that was one of the things that we surveyed our members on in relation to their own mental health. And as you say, 58% of that survey in 2020 said that they were worried about their physical and mental health.
Yes. And I can perhaps just inform you, Mr. Poolman, that the inquiry is aware of research that has been done in relation to the impact on the mental health of the nursing and care profession. And we are aware of various research projects, including some collaborative research carried out by the Universities of Dundee and Edinburgh in relation particularly to the incidence of PTSD, I think, affecting nurses in intensive care units. So we are aware of this, and we will be looking at that in the context of of impacts. Two other matters that you refer to. I'm quite interested in the redeployment of nurses to areas that were beyond their usual areas of expertise. Now, that is something that you raise, and indeed your colleague, Mrs. McKenna, raises in her evidence. And just from your perspective, what was the RCN's view on nursing staff being redeployed, presumably at short notice, to situations that were not within their usual area of expertise or comfort?
To set into context, prior to the pandemic, there was significant issues with the nursing workforce across health and social care. There was significant vacancies. That in itself contributed to the requirement, as the pandemic developed, the requirement for staff to work in specific areas, for example ICU, and that required many staff to be redeployed because of the need, because of how things were developing, but of course they required a period of time of adjustment, because not all individuals that were moved obviously had the recent experience of working in these areas, and that in itself was difficult for the staff, although they were given support and education to allow them to go into these areas. It was extremely difficult, because they were being asked to move in areas that, to be quite frank, they wouldn't have been their area of choice to work in, but they were moved from all types of areas. And part of that was because we didn't have a sufficient workforce.
And that's something that your colleague, Mrs. McKenna, will deal with in a little more detail, about the deficiencies in the numbers of the nursing workforce, which was pre-existing the pandemic. But could I just take you a little further on that, if I may? The idea of a nurse with a specialised training being, or possibly not having a specialised training, and being deployed into an area which one would normally expect there to be specialised training. Does the RCN, I suppose put it this way, accept that as a necessity, or do you disapprove of it?
Well, I think the issue is that people should be put in places they don't have the competence to work in. And of course, nurses have a general level of education for qualifying, and then their experience is built on that. But as you move into areas, there is additional training that requires to be given, and people need time to acclimatise and get used to working in these areas, and to build up the knowledge and expertise to be proficient. And of course, we would always suggest that people should be given the time and the induction and the support to do that when they move to a new area. But because of the necessities, as you say, of the pandemic, that had to happen really quickly, and many staff were not. There wasn't a lot of choice. It was, the issue was they were asked to be moved in the most positive way, but then they were moved to areas that they weren't used to working in.
Now, I'm not going to ask you what effect that might have had on patient safety, but I'm going to ask you what view your members took as to whether they felt fully equipped to deal with patient safety in those situations.
I think many members have expressed that they didn't feel that they had adequate time, or they did get support, but was it adequate enough, because it was done at such rapid pace, and that had a significant impact on individuals when they were being asked to be moved. And as I say, they were asked to move, but in all intents and purposes, people were redeployed because that was what the system needed at the time.
They were told to move.
Basically.
You also mentioned professional dilemmas, and you give the example of whether or not to treat patients without wearing PPE. Now, can you just expand on that a little?
I think as you'll definitely hear from my colleague, in relation to PPE and the infection control guidance. The guidance changed on a repeated basis throughout the pandemic, and that led people to not be, to have some concerns around about, what PPE they should use. That doesn't. Let's not go into the issue about the availability of it, but that dilemma around about what PPE should be used, how you should care for somebody. Of course, that brought dilemmas in relation to it. Also brought dilemma in relation to individuals in relation to their attendance at work. For example, if they were experiencing symptoms themselves, and especially in the very early stages of the pandemic, when there wasn't testing, that of course led people to the professional dilemma about being at work if they suspected they had one symptom, if you like, of the virus itself. So that did leave people with dilemmas around about attending work, how they conducted themselves at work, because there was a crisis on building, and of course there was a lack of workforce.
I think one of the issues that your colleague Mrs. McKenna touches upon is, and quotes from some of your members, making the point that they felt that they were unable to give of their best in certain situations. Was that something that was a repeated concern for your membership?
Yeah, that definitely came through in one-to-one contact, but also in our surveys in relation to members. One, didn't feel prepared, but they also didn't feel that they had, for example, the right guidance, and PPE was a significant issue because there wasn't the provision that we believe there should have been.
Yeah. Well, your colleagues will deal with that.
They will.
In more detail. The other point I'd like to ask you about in this list in paragraph 13 is that the comment you make in relation to nursing staff from ethnic minorities. And you say that such staff sought specific support, as in the general population, they suffered poorer outcomes of COVID-19 infection. And this was exacerbated by existing structural inequalities and institutional bias within the healthcare system. Now, you've got a perception, obviously, of what structural inequalities and institutional bias within the healthcare system amounts to. Can you tell us what it is?
Well, in relation to our colleagues, they experience different things. So, for example, if you look at the evidence in relation to pay, they're usually employed in the lower grades. They're usually find it more difficult to get promoted, for example. So they don't, I would suggest, feel they get as equal opportunity as other colleagues in relation to healthcare.
And what's the root cause of that?
I think some of them is societal in relation to that, and I think we as an organisation, equality, diversity and inclusion is a huge issue for us in relation to make sure everybody is recognised equally, but evidence would show that that doesn't happen, and at times there is, whether it's known or unknown bias is shown towards individuals who are not from ethnic minorities, and I think, as I say, that is shown through for if we look at individuals who are in senior positions, for example. Right.
You also, sorry, having said that was the last point from paragraph 13, there's another one, and that's long COVID. you mention it, and it's something that your colleagues deal with in more detail. But from your strategic viewpoint, and as we're progressing on, what concerns do you have of the impact that long COVID is having on the workforce?
Well, I think there's a number of concerns. One is the true recognition that long COVID exists within the workforce, and because people are presenting with all different types of symptoms. I think that's one significant concern. I think it's also the concern around about how we support individuals who are experiencing across health and social care the symptoms of long COVID to one, support them, and hopefully to keep them within employment. I think that's something that's hugely important. I do think also it's about the recognition in law and it being recognised as an industrial illness, yes. And also how people are, if they do have to leave their employment, are compensated for what, in essence, for many was an illness that they contracted at work.
And is that something about which your college is campaigning?
Indeed it is.
Can I ask you, is it something that you're campaigning successfully about?
I don't think we've been successful enough up to this point. There's much that governments can do, and we'll continue to do that both in Scotland and across the UK.
Okay. Right. Can I move on to talk about your engagement with the Scottish Government? Obviously, you had a pre-existing engagement with the Scottish Government. And from what I read from your statement, that was a fairly, but bluntly, fairly good engagement. Would I be correct in that?
Yes, I think we're fortunate in Scotland that we do have quite proactive conversations with both government at ministerial level, but also at department level. So, for example, the Chief Nursing Officer's Department, we have regular engagement and have done over a number of years, which is generally a positive way to communicate and do business.
You provide us with a list, quite an extensive list, of various groups that the RCN was involved in. And can I just ask you about one, please, and that's CPAG. That's how I've heard it referred to it. I don't know whether it's divided out. That's CPAG, it's the second that's referred to. It's the Clinical Professional Advisory Group. And it's said to be care home specific with a range of stakeholders and Scottish Government. And can you tell me, I know your colleague Mrs. McKenna was on that group, was your representative on that group.
She was.
Tell us a little bit about it from your strategic perspective.
Well, it was an opportunity for us to raise specific issues within that care, for that care environment. Mrs. McKenna obviously raised a number of concerns that we had. For example, the provision of PPE within the care home sector. That was one of the significant issues very early on that was raised, and many other issues that developed within that specific area of care.
Yes. Obviously, these groups were established to address various issues within the pandemic. And clearly your organisation, the membership stretches across both the NHS into the care sector, both care homes and care in the community sector. So far as you are concerned, and again from your strategic perspective, do you feel that sufficient information was obtained and taken on board for the care sector at the outset of the pandemic?
No, I think on reflection that's certainly not been the case for a number of issues. If I take two issues in specific that might be worthy of note,
yes,
to give example, PPE provision, for example, huge difficulty in both procurement and the availability of PPE within the care home sector. I mean, it was an issue within the NHS as well, of course, but it was more of an issue, I would say, more acute in areas of the independent and social care areas. One of the other issues were around about how the workforce was supported. Within the NHS, very quickly, around about terms and conditions, although there was, I would say, there was definitely issues in relation to some of the guidance that was provided to individuals who, for example, had to self-isolate. We very quickly dealt with, for example, pay terms and conditions in the NHS, and dealt with that so people shouldn't suffer detriment, although there was some issues that came up during the pandemic, but we did deal with it quite rapidly because we had existing structures. Whereas, for example, in the social care sector, those who cover for when they were absent in relation to pay, it was sporadic around about not only statutory sick pay was paid, but there was very little occupational sick pay. Therefore, it put huge pressure on individuals to make choices. And if you've got to remember, a lot of individuals are, we would class as low paid in social care, had to make very difficult decisions about coming to work or not coming to work and the lack of pay. And I have to say, it took Scottish Government quite a period of time to deal with that ourselves, through Mr Provan, through the Workforce Senior Leadership Group and others, and other organisations actually campaigned with Scottish Government to try and make a difference, which they did ultimately, to be fair, but it took more time than it should have.
One thing I've heard, and I'd like your comment on it, Mr Poolman, is that at the outset of the pandemic, there was nobody representing the care sector at the same level as, for example, the Chief Medical Officer or the Chief Nursing Officer, that there was nobody representing the care sector at that level. Would you agree with that? And do you see that as a deficiency?
I think there is a deficiency across the system about where the care sector linked in, and I think the pandemic has shown that to be the case. I'm sure colleagues, the Chief Medical Officer and the Chief Nursing Officer, would say that they have a responsibility across the entirety of health and social care, but I do think there was an issue of around about where key individuals from key groups linked in. So, for example, the Workforce Senior Leadership Group, it took a bit of time before they were invited in to the group. So I think that was an example of the two systems not exactly meeting each other and having equality from day one.
Mm-hmm. Pretty crudely, was the care sector seen as something of a poor relative?
I would like to describe it as that, I have to say.
No, I'll take that responsibility.
Yeah, but for the point of view of did the care sector have more difficulties in having their issues addressed, I would say that's been very apparent, in both at the time and since the pandemic.
Could I go to paragraph 30 of your statement? And you make the point there that in terms of planning for the pandemic and resilience exercise, RCN Scotland was not involved.
No.
It may seem rather strange.
I think when you look at it in hindsight, I think it was, but I think the one thing that ourselves in this generation now know, that planning is essential. But no, we were not involved in planning for a pandemic or the resilience exercises, either locally or nationally. And actually, you know, we absolutely believe as a key stakeholder that going forward we should be.
Yes. Let's take hindsight out of it. let's go back to the time of the pandemic, the start of the pandemic. It's not going to take a genius to work out that your membership are going to be at the front line of the treatment and care of persons infected with the virus and in various ways. And that very likely that is going to place an incredible burden on your membership. Surely it didn't need hindsight to suggest that your organisation should have been involved in giving your input into how things could be structured for the response to the pandemic.
I couldn't agree more. I mean, at the end of the day, it was very clear our members would be at the centre of any response to any type of epidemic or pandemic, but we weren't involved in detail in the planning for it.
Yes. And in practical terms, what would you, if you were saying, we want to plan for a future pandemic of a similar type as the COVID-19 pandemic. Let's assume it's going to be the same type. If you're going to plan for that, what sort of involvement would your organisation wish to see having in that exercise?
Well, we'd want to be involved in all the discussions around about the development of the protocols, procedures, the guidance in relation to what the workforce and the public should be given. We'd want to be involved in that because I think, of course, hindsight does come into it in respect of what we've learned. So we think we would play quite a key role in the support and the expertise that both our organisation and our membership could bring to that aspect of planning, but also to plan for the more practical elements in respect of both the support, development and preparation of the workforce to be able to react to a future pandemic if it does come that we need to deal with that. One of the things that we need to do is also think around about the workforce that you would require to be able to fight a pandemic and the flexibility of that. We clearly already had vacancies, and the pandemic increased the requirement and need for especially healthcare staff to look after people. So being involved in how you do that and being involved in thinking around about how we were to react, we think would be a key role for a stakeholder like ourselves.
Can I interject, Mr. Gale? Mr. Poolman, this may sound a harsh question. It's not intended to be a harsh question, but it's perfectly obvious from what you've just said in response to the questions by Mr. Gale that you were not involved. And I understand what you say about that. But the RCN is a large organisation, obviously, and as you have just said, you would have a desire to be involved in any future planning, and I can understand that desire. Did you as an organisation, I suspect I know the answer, but did you as an organisation do any internal pre-planning for pandemics of any sort prior to the one we've just experienced?
Not in the detail, I would suggest. If you looked at some of our guidance that we produced to members, could it be used in the pandemic? Absolutely, but we didn't have, if you like, an exercise to plan for a pandemic. So no, we didn't.
Thank you. Sorry, Mr. Gill.
No trouble. Just an area of dispute with the Scottish Government was the question of whether COVID was an airborne virus, or rather than one spread by droplets. And I think you make reference to this particularly in paragraph 40 of your statement. Can you just explain how that disagreement manifested itself?
Partly due to the guidance that was published in Scotland but across the UK in relation to PPE and the provision of what PPE should be used and when it should be used. Very early on, as in our view, the evidence started to show that the transmission, and especially with as the variants developed, we believe the evidence supported that the virus was airborne in its transmission, and that in itself would mean that you need to look at look at the aspect of PPE, but also an important aspect, which was the ventilation within healthcare environments where people were being looked after because of the transition route, and then of course individuals being exposed to the virus. So that became evident to us quite early on. We started to raise it both in a regular contact through the various groups, both informally and formally, with Scottish Government, but they, to be fair, didn't respond to that and didn't accept the position that we were taking.
I think you put it fairly bluntly at paragraph 46 of your statement. You say, ultimately RCN Scotland considers that there is a serious lack of engagement by the Scottish Government to consider the growing international scientific evidence of airborne transmission of COVID-19, but this was ultimately dismissed in favour of droplet transmission, despite no evidence supporting this, and the impact of these decisions require to be critically examined by this inquiry. So can you just give us a little flavour of how Scottish Government set its face against what you were arguing for and what you were saying had a growing international scientific evidence base for?
Very early on, there was a rapid review of literature in relation to the transmission of the virus, and the government preferred that. Over the period late 2020 into 2021, we ourselves actually commissioned an independent review of that process that actually came out and agreed with our position, and there was developing scientific evidence. Numerous papers were being published about the transmission of the virus, and as I say, as the variants changed, it became much more clearer that for us it was airborne transmitted. And I have to say the government, they refused to really take that on board and change their guidance or evidence to reflect that, and that I have to say was and probably remains an area of dispute between ourselves and the Scottish Government.
Yes. I think the World Health Organization categorised COVID as an airborne virus, which, as you say in paragraph 40, vindicated the approach that you were taking.
It did. It did. In our view, it should have been that you take the approach of risk and follow the evidence, and the evidence absolutely supported it was airborne transmission, which would have had and should have had an impact on the recommendations of what protective equipment that staff used and when they used it.
In the last sentence of paragraph 40, you say that this was too late for those who caught COVID-19 as a result of inadequate PPE and the impact it has had on individuals. That's something you stand by.
Absolutely, we stand by it, and of course you can't look forward and actually categorically say what the consequences are, but we believe that if we had at that point in time recognised fully in the guidance that it would have made a difference for some, and some individuals wouldn't have contracted COVID and the consequences that had on them.
Now, the inadequacy of the PPE is something that your colleagues will deal with, but are you able to just give us a flavour of what is being considered there?
Well, the inadequacy of PPE, I think, was well reported at the time and since. The inadequacy of it was staggering in some way. When you look at it, there was members of staff who were being asked to reuse PPE that wasn't designed to be reused, for example, because there wasn't adequate supplies. The distribution initially was poor, as well as the provision of it. The type of PPE in itself was not always fit for the situation that was being asked to be used on, whether it should have been, people should have had gowns and they were just given plastic aprons, for example, or indeed the design of some of the PPE. So nursing is a predominantly female profession, and many of the masks were not designed in smaller sizes. So we had huge issues at times where they were doing the fit testing, is what they called it, for an FFP3 mask, and many nurses were not passing the fit testing because there wasn't the designer mask available.
Yes, thank you. Could I just take you on almost finally to what you say in paragraphs 48 and 49 regarding care and nursing homes, and also the district nursing situation. You say that the RCN was not involved in the decisions that were taken regarding the transfer to or from homes. Now, we're talking here about the strategic decisions that were taken, not the individual clinical decisions that were taken. Can you tell us what could and indeed would have been your position had you been brought into that discussion?
As I say, we weren't involved. These were decisions that were made at Scottish Government level. The issue for us would have been, if brought in, would have been to absolutely establish what the evidence was at that time and what the evidence supported in relation to the risk of the transfers and what precautions could have been taken. These would be things that we it's difficult. We weren't involved in these discussions or decisions, so it's difficult for me to ascertain what we would have put in at the time. But
I appreciate that. But from the information that you gleaned from your membership, do you think that the sort of precautions that you're talking about had been taken into account in the decisions to transfer persons from hospitals into care homes and vice versa?
I think initially, quite clearly, there was a decision made that there was going to be a need for hospitals and acute beds, and I think the decisions were made on the basis of making sure there was availability to look after acutely ill people, and that had a major impact on what the Scottish Government and colleagues' decisions were at that time.
You do say in paragraph 49 that you refer to the concern expressed by your members regarding the arbitrary discharging or preventing of discharge from that situation. Now, that seems to be suggestive that there was perhaps not the level of precaution taken if it was arbitrary. Is that what you're trying to get across?
I think the issue was there was general, the advice came from Scottish Government, and then that had an impact about how that advice was carried through within the healthcare environment, and that left a lot of professionals to make very difficult decisions that they quite clearly were told to do something that they, when applying their clinical assessment, may not have made these decisions.
Yes.
For the avoidance of doubt, you've used the terms advice and required to do, which are mutually inconsistent or potentially mutually inconsistent. And I just want to be clear what your understanding of the situation was. Advice was given in relation to discharge by Scottish Government, and clinicians who ultimately had the responsibility for making a decision on discharge, and this is the important part, they were influenced or they felt bound. Which is it, to discharge?
I think they felt influenced. By, and I would, and if I just go back and be very clear, I think it's the guidance that they received in relation to these processes at the time, because we were preparing or starting to deal with the outcome of the pandemic or the results of it.
I do appreciate, obviously, the burden placed upon a clinician made with that decision. One presumably doesn't ignore advice or guidance from a government, but that is the situation that the clinician was in.
Yeah, that's the situation clinicians were put in.
Yeah. Do you think that's right?
I think we should
Perhaps
always...
It's not a question for you, to be fair.
I think in my own personal position would be, I think at the end of the day, guidance is provided, but I think ultimately decisions in relation to patients being discharged or being admitted to hospital should be left with the clinicians who are dealing with the situation and their experience and knowledge to guide them on that.
No, I understand that. Probably it was an unfair question to you, to be fair. We should ask, no doubt we will ask the clinicians when we hear from them, Mr. Gill.
Yes. Just one point that perhaps follows on from what you've said in paragraphs 48 and 49 is the last sentence in paragraph 49, where you say the pandemic has emphasised the need to ensure the community and care home sectors are properly represented in planning to scale up the nursing workforce for future pandemics and ensure a whole system approach. It's probably obvious, but what is a whole system approach?
I think you're right. It's obvious. We should absolutely look at the health and social care system in its entirety, not just elements of it, and not prefer one over the other. But that's systemic and around about how systems work together and how they're set up. And we certainly need to make sure that the nursing element of that is recognised equally across both health but also social care.
Can I ask you now about do not attempt CPR? You make your position on behalf of the RCN very clear in paragraph 51 that it has always been your position that there must never be a blanket use of such certificates, and that end-of-life care must always be delivered with the utmost compassion and part of a personalised care plan. And you refer to your own press release that you issued in the course of the pandemic. Was there a reason for issuing that press release?
Absolutely. The reason was that it became an issue that had been raised through our membership in relation to the approach that was being taken in relation to these the DNA, the CPRs, and we felt it was absolutely important that we re-emphasised the importance of individualised care in all circumstances. These should not be blanketly used, and when you're going through end of life in whatever situation, you should be involving the patient if possible, but of course their family and loved ones in relation to any decisions that are made. It should always be on an individual basis. That's been our position for some time and continues to be our position.
Yes. And I think you probably answered what was going to be my last question on this, was that this would involve, where appropriate, discussion with the patient and also discussion with the patient's family, if there was a family.
Indeed. And of course the pandemic caused difficulties with that because of people's access to being in hospital or in a care home. But of course, there was other ways of communicating, and that's incredibly important for anybody's end of life that is done in the most compassionate way possible, and to meet the wishes of the individual and their families.
Now, Mr. Poolman, can I take you to your lessons to be learned? And again, this probably encapsulates several of the matters that you've addressed so far. But I think probably it's best that I leave it to you to read paragraph 57 of your statement.
Would you like me to read it out?
Yes, please. Yes.
The RCN considers that in order to be properly prepared for a future pandemic, key stakeholders in the provision of health and social care require to be involved to influence of all key decision-making and guidance. As mentioned prior to and during the COVID-19 pandemic, RCN Scotland was not fully involved in the design of national guidance on PPE and infection control. After considering the impact, we believe full and proper engagement with the nursing profession on infection control would help to ensure future national guidance is robust, fully informed and, importantly, evidence-based. More importantly, the Government must identify ways to address the staffing and recruitment crisis faced by the health and social care workforce across a number of clinical settings. Without an adequate number of medical, clinical and healthcare workers with the right mix of skills and who are able to deliver the appropriate standard of care to meet the demand of the country at the present time, in the absence of a pandemic, then there is no chance at all that the deem created by any future pandemic will be close to being met.
Right. Well, thank you very much, Mr. Poolman. As is the norm, I will ask you, is there anything that you would like to add to the material you've placed before the inquiry in your statement and amplified in the discussion that we've had this morning?
I think I would just like to amplify the absolutely having the benefit of attending and giving evidence to the inquiry. The RCN wishes to participate and learn like everybody else in relation to the lessons that we need to learn as across health and social care, but also as a society, of how we can, if we ever have to, react and deal with the pandemic in the future. And my colleagues will add to my evidence as you take that from them later this morning.
Thank you very much, Mr. Poolman. Thank you, my lord.
Thank you, Mr. Poolman. Very good. 12 o'clock? 12 o'clock, I beg your pardon. 11 o'clock, Mr. Gill.
Yes. It's Mr. Dunlop who's taking the next witness.
Very good. Thank you.
Morning, my lord. This morning I have one witness, Mr Norman Provan.
Good morning, Mr. Provan.
For the benefit of us, was the transcript in your own notes, my lord, the reference number of his witness statement is SCI WT 0491 dash, and with most of them it's 5 zeros and a 1.
Yeah.
Thank you, my lord. Unless there are any preliminary matters, just thank you.
You start.
Thank you. Can you provide the inquiry with your full name, please?
Norman Provan.
Okay. Mr Provan, I think you wanted to say something before I got into this. Was the body of the questioning this morning?
Yes, in Mr Poolman's evidence, he gave an organisational statement giving the RCN's condolences to those who lost loved ones during the pandemic and those who continue to be affected by it. I won't go through the statement again, but I would just reiterate that personally.
Thank you. Can you provide us with your position within the Royal College of Nursing, please?
I'm the Associate Director of the Royal College of Nursing in Scotland, and my particular responsibilities are for the employment relations functions.
Okay. And you've provided a statement to the inquiry which contains a lot of detail, and I don't propose to go through all of that in the hour or so that we have this morning. You identify your qualifications and employment history at paragraphs 3 and 4, and thereafter you move on and you tell us at paragraph 6 of the statement that you're part of a strategic group established by the Scottish Government in response to the pandemic, and you say that that group's role was to manage the workforce's response to the pandemic. Can you tell me who was the chair of that group?
It was a senior civil servant in Scottish Government who chaired the group. When it was initially put together, it was the first group that was put together in relation to pandemic response, and then many of the other groups in my statement, and indeed that Mrs McKenna, came from that because we were able to hive the work off to other groups to do piece of work rather than the strategic group. So, for example, initially, when that group met, when it was first put together, we met twice a day, 7 days a week at the very beginning, and over time that lessened off. And other groups were established to take on particular issues so that the group didn't have to consider anything, but it really was about the workforce response.
We may hear from Scottish Government witnesses later in the inquiry process. You said it was a senior civil servant. Do you remember his or her name?
I think the chair of it changed, and I can't recall the name. It might come to me, but
no, don't worry.
I think
if you can't remember.
It was Gillian.
I'm not going to ask you to guess.
Gillian Russell.
Oh, thank you. What kind of topics were discussed in the early stages of the pandemic? I'm really thinking kind of late March, early April at this group.
It was a multi-agency group. I think that's important to note. So it wasn't just the NHS. So there was stakeholder involvement from primary care, secondary care, and indeed the care home sector. Initially, very initially, it was largely about the workforce, having sufficient workforce, how we would deploy them, and particular issues in relation to the supply and distribution of PPE.
You maybe answered my next question, but I'll just ask you anyway. What kind of decisions were made? Was it just discussions in principle, or were decisions made about what we're going to do about workforce or what we're going to do about PPE?
It was a bit of both. Some decisions we made on the day, and they would be applied across the whole of the health and social care system, sometimes from the very next day. Other things we would decide would take longer to put in place. So, for example, in terms of the procurement of PPE gowns, for example, which are reusable, washable gowns, we were making decisions about stepping up the laundry facilities so that all of it could be bagged, sent to laundries and returned back into the system quite quickly. That didn't happen quickly, but the deployment of staff, some of those decisions were made immediately and were implemented, as I say, in some cases almost from the next day.
Okay, thank you. We see in paragraph 8 of your statement, there's a list of other groups that you were also a member of. I don't propose to go through those, but we see there's a national PPE oversight group. Those groups, did any of those, and it may have been too early in the pandemic to have been involved in it, but did any of those groups deal with long COVID?
No, not at that point in time.
In paragraph 11 of your statement, you identify that there were issues where the Scottish Government didn't act in relation to concerns raised by the Royal College. Could you give me a couple of examples and tell me when those concerns were raised?
Sure. Most predominantly, it was the issue about the supply of certain types of PPE. The Royal College of Nursing and other stakeholders raised their concerns about the use of, for example, fluid surgical resistant masks, which are open at the side, where we felt it would have been more useful for all staff to have access to FFP3 masks, which form a seal and are therefore better, including issues such as aprons and visors. And that's the one thing out of all of the engagement that we had with the Scottish Government that I regret that the Scottish Government did not act more fully on the concerns that we had. Within the first year of the pandemic, particularly as there was new variants appearing which were more virulent, they spread more easily and more quickly. We wrote in the January of 2021, almost a year into the pandemic, to say that there was emerging evidence about this not being a droplet past infection but an airborne one, and urged them to change their guidance, and they didn't, and to this date never have.
And did they explain why they didn't?
They constantly said that they were convinced by the work of RHI, which was a Scottish group that was providing guidance for the whole of the UK in relation to the modality of the infection spread. In pure logic terms, there were some things. So if I could illustrate with an example, fairly early in the pandemic, hospitals were being filled with people who had COVID. So wards that did surgical interventions were being transferred into medical wards because that's what the need was. Many people would come into hospital, would deteriorate, and some of them ended up in ICU. So if you went into ICU, people had all of the gowns and the masks and the visors and the FFP3 masks. And I remember having a discussion very early at the Workforce Senior Leadership Group, and we raised an issue in relation to the Victoria Hospital in Kirkcaldy and Fife, where we pointed out that in the ICU department, where they had all of the PPE, there was one member of staff off sick with COVID. In a medical ward that fed the ICU, for the want of a better word, there were 17 members of staff off sick with COVID with different PPE. Simple logic tells you that actually the issue here is if they had better PPE. So bear in mind that we weren't being listened to, the RCN then commissioned a report where we had experts look at the guidance, and they were fairly critical of the conclusions that were reached by RHI in terms of the guidance that they produced and indeed the evidence base that they had used to make those guidance. So we had commissioned a specialist report which we furnished the Scottish Government with in February 2021, and again they didn't respond adequately to that. They insisted that their guidance was sufficient.
And I think, correct me if I'm wrong, but I think you said that to date they still do not accept it. Was that correct? Did I pick it up correctly?
I think now that the pandemic is seen as being over, they accept the WHO's statement now that it is an airborne infection, but certainly during the whole of the pandemic and every iteration of the guidance that they put out maintained that it was a droplet infection and not an airborne infection.
Okay, thank you. At paragraph 12 of your statement, you discuss pre-pandemic planning, and you tell us that the Royal College wasn't involved in that pre-pandemic planning. With the benefit of hindsight, are you suggesting that it would have been advantageous if you had been involved in that?
The RCN did have some involvement, but not in the very specific exercises about how you would deal with an outbreak. We did have some discussions prior to my time in post about how the workforce would respond. But in terms of the type of desktop exercises and modelling that you would do based on other outbreaks in other countries, we were never invited to be involved in that. And certainly post this pandemic, I think that any exercises that they do to plan for future pandemics, there is learning about all of the stakeholders who were involved, and I certainly think that we would have something to contribute to that.
But you do say, you go on to say in the next paragraph that you were involved in the pandemic, the planning, if you like, once it commenced. What type of planning were you involved with?
Really the day-to-day decisions from the Workforce Senior Leadership Group and all the other groups that we've put. I think it's worth noting that the Scottish Government's engagement model with trade unions and professional organisations like the RCN in Scotland is good. We are generally invited to the table for these things, and that was maintained throughout the pandemic. So ourselves as the Royal College, along with other Royal Colleges and other trade unions, were intrinsically involved with all of the groups that were managing it. We weren't doing our shouting from the sidelines.
Okay, and it might be a benefit. The Royal College, is that simply a professional organisation, or does it have a trade union?
It has both.
It has both.
And there are very few that have both a professional Royal College and a trade union. And in fact, in terms of our evidence, it's why myself and Mrs McKenna are given different evidence. We have different portfolios, so I manage the trade union and legal aspects for the Royal College of Nursing, and Eileen manages the professional practice and learning elements of it.
And this may actually be a question that would be more appropriately put to Eileen on that basis, but you say at paragraph 19 that nurses required to transfer to the specialist areas that they didn't normally work within. Did nursing staff require to receive training because of the pandemic?
Yes. In simple terms, nursing, like many professions, after you originally qualify, then splits into a number of specialist areas. So, for example, if you're a nurse working in an orthopaedic trauma ward, you wouldn't necessarily be competent to go and work in a general medical ward, which is what was required during the pandemic. But of course, all of the demand for services was general medical and specialist ICU, because that's everybody was getting COVID and everybody was being admitted to hospital for that. So many nurses were required to transfer from the specialist area that they were most competent and familiar in to work in areas that they were less confident or familiar in working in.
In terms of that training, how long, or maybe you can't say, but how long would the training take for an average member of the Royal College? They weren't
taken aside and trained before they were put in. They were put in and trained on the job, right, because that was absolutely necessary. And there are some areas that would have been more difficult than others. There are certain transferable skills all nurses would have a reasonable degree of competence in. But to move from one area to an ICU, where you would normally be expected to have a postgraduate qualification, a specialist qualification for nursing that type of patient, there were nurses who went into ICU who never managed to get that qualification during the pandemic because it simply wasn't possible to do so. They were certainly working under the direction of nurses who did have it, but they wouldn't have been as confident or competent as those nurses because they weren't trained to be.
Is there something that could be done for the future in terms of lessons learned?
Difficult to say, because pandemics happen so infrequently that with anything, to keep your skills up to date, you could be academically trained in something, but unless you're working in it every day, I would suggest it wouldn't be easy. You could perhaps do some form of rotation where people rotated from different clinical areas, but that would then take away from the specialist aspect of people working in areas. So I think it's an issue worth considering, but I don't think there's any simple answer to that one.
Moving on to paragraphs 24 and 25 of your statement, you go on to discuss testing, and you identify that, in your opinion, there was no reliable testing at the outset of the pandemic. Did the testing improve as we're looking at the period, essentially from the beginning of 2020 to the end of 2022? In your opinion, did the testing improve during that period, and if so, when?
Yes, without question. I mean, there was no test initially for COVID. People were coming into hospital assumed to have COVID because of their clinical symptoms. So until such time as the diagnostic test was made available, and then it was PCR testing, and those were regionally set up. So people would be asked to drive to Edinburgh Airport to be tested, for example, and there were sites all over Scotland for people to do that. There was a degree of testing in hospital, PCR testing, but there wasn't the lab capability to do that at scale. So over time it did get better as the Scottish Government commissioned more lab ability to test those assays, and over time then when the strip testing was put in place, the self-testing mechanism, which was quite easily distributed to staff, and they were asked to test twice a week, then by that time the testing was reasonably sophisticated.
Thank you. In paragraph 25, and I'll come on to long COVID shortly, but you state that there were many staff that essentially contracted long COVID and they're facing financial detriment, and so some are now unable to work. do you have any statistics, essentially, of your members that have contracted long COVID?
Continues to grow. We have 35 cases, personal injury cases, that we have lodged and are currently assisted, and we have about 15 more at the moment. But the arrangements that were put in place for people in their workplace for occupational triggers if they're off work, people were treated as at work and paid as at work if they were off sick. But now many of those nurses are coming to the end of that and are being dismissed from their employment because they're not fit to return to work. So many nurses are now coming to us some years down the line saying that they have been affected over a long number of years, haven't been fit enough to return to work, or have attempted to return to work but haven't done so successfully, and are now being dismissed from their positions.
And just to go back to the kind of the original question, you identified a number of claimants in actions, but not necessarily everybody that's caught long COVID will have been or is a claimant. Do you have any database or statistics in relation to members who have contracted long COVID, or is it simply those ones who are pursuing a claim for damages?
I have the stats about the ones who have claimed for damages, but we have many more members who complain of having long COVID, and I think that will continue to grow as time goes on. I still see cases coming in where people are saying they hadn't had any contact with us at time because they were being paid occupationally as if at work, and it's only now when they're not that they're coming to us and saying, actually, I've had this for 2 years.
Okay. And perhaps this might help identify the answer to my question, because I'm really just interested whether there is essentially a number in terms of the members of the Royal College who have long COVID. But you identify in paragraph 27 of your statement that you raised concerns essentially that there was a lack of reporting of your members contracting workplace COVID, and if the reporting, what do you say if it had been reported? The reporting of COVID had been carried out the way you would have had it done, what difference would that have made, do you say?
There were differences in the way that parts of the system dealt with it. I wrote personally to every chief executive of every NHS board in Scotland, reminding them of their responsibilities to record what might have been occupationally derived disease and to report that through the RIDOR mechanism. I got different responses from some of those chief executives, some of them setting out quite clearly that they had put mechanisms in place to try and ascertain whether or not somebody had nosocomial or occupationally derived infection and reporting it. And I remember another chief executive whose letter quite insultingly basically said we're giving people PPE so it's impossible for them to get it at their work, which I thought was a spurious way to respond to something that... And then the guidance that came out from Scottish Government, because through the Workforce Senior Leadership Group I raised this and said that Scottish Government should reinforce the guidance to employers, which they did. But there was a disconnect between the advice that they gave and the mechanism for testing. So the advice that they gave was that any nurses who they thought might have occupationally derived COVID or went off sick from work with COVID, which might have been occupationally derived, and they had a PCR test to demonstrate that it should be reported via COVID. But by that time we'd moved into the mechanism where people were self-testing and it wasn't PCR tests that were being used. So in fact, there were probably many, many more nurses who had contracted COVID, possibly at work, but because they didn't have a PCR test, their employer never recorded that or reported to the Health and Safety Executive. And had the Health and Safety Executive got hundreds or thousands of more referrals for people who had been occupationally derived, they may, for example, have insisted on different control mechanisms being put into place, and that never happened.
Is there, sorry, I don't want to kind of press you on it, you may not know, but is there a database of how many times, so if a member of the Royal College contracts COVID, is there any database that shows how many times they've contracted it, occupationally contracted it?
Not that I'm aware of in terms of central health, but I know that Public Health Scotland did some outbreak work with outbreaks in hospitals. So at the very beginning, if nurses went off sick, then it was assumed they'd COVID, there was no testing. Then you get to the point where there is testing and people are still fairly restricted in terms of lockdown, so they're technically at home or at their work and perhaps visiting the supermarket once a week. But then towards the end of the pandemic, of course, everything was open, so it becomes more difficult to say if a nurse got COVID whether or not they got it at work. But bearing in mind that patients who were being admitted to hospital, not as an emergency, but in a planned way. Those patients were tested prior to coming into hospital, so you knew that patients, when they come into hospital, were COVID-free or COVID positive. And what was known is that some of those patients that came in that were COVID-free when they came into hospital, a few days later then tested positive. There was knowledge of the length of time, the incubation period for COVID, so it was likely then that those people got it in hospital, either from other patients, from nurses, or indeed gave it to nurses. And I know that Public Health Scotland did do some outbreak testing using PCR, but I don't have access to that data.
Okay. Now I'll move on to a new topic, but PPE again. And at paragraph 36 of your statement, you identify that PPE was required in a variety of settings, from ICU and hospitals to care homes. Are you aware of your members experiencing any difference in either the availability or the suitability of PPE depending on where they worked?
Yes, so take aside the comment I made earlier about ICU having all the equipment, in other wards which were feeding them having less equipment. Yes, particularly in areas out with acute district general hospitals, so in care homes and in the community, for example. Care homes are often small providers, so they had their own method of purchasing PPE, and of course every health system in the world was trying to get great amounts of PPE at quite short notice at the beginning of the pandemic. So for them it was particularly difficult to secure an increase in their supply chain. Through the Workforce Senior Leadership Group, where we raised this, and one of the things that I would commend Scottish Government for was the setting up of hubs, which meant that those environments like care homes, if they had difficulty securing their own PPE, could phone and they would be supplied PPE from hubs, which was from the NHS stock. But certainly there appeared to be a hierarchy the further you got away from the very acute environments to both the availability and the type of PPE that was available.
Thank you. And in terms of the hubs, I think we see later that you discuss community hubs. Is that the hubs that you're talking about? And in terms of the hierarchy, am I correct in understanding that the hierarchy is ICU, the gold standard, if you like, of PPE, and then as it filtered down through different wards in the hospital, it wasn't that gold standard, and then as it got further down to, say, primary care, GPs and care homes, it was of a lower standard again. Or am I misunderstanding you?
Yeah, I think that's fair, particularly at the beginning, when the big issue, of course, was about securing the amount of PPE that we required. So I know that in community there was certainly more frequent reuse of PPE and less of it. I also think that there was a degree of hoarding happened when PPE came in, and through National Shared Services and the Workforce Senior Leadership Group, within 6 months of the pandemic being in place, there was a fairly sophisticated system where on a weekly basis we were given information about exactly how much PPE was in stock for every item, where it was held, largely at a distribution centre in South Lanarkshire, and how much of it had been distributed to every single hospital in Scotland, and how much that they had in reserve. So the Scottish Government, through the Workforce Senior Leadership Group, did respond to that in a way to try and positively address that issue.
Okay. And I'll maybe come on to the National Shared Services shortly, because I think you deal with that in paragraph 38 of your statement. But just to pick you up on one point there, you talked about the amount of PPE. Now, I think there's possibly two issues. There's the sufficient, essentially whether there's enough masks or gowns or so forth, gloves, and there's the issue of whether it's suitable for purpose. Were they both issues, or was there enough but it wasn't suitable, or was there a suitable one but it wasn't enough? Can you?
They were both.
The issue was both?
Yeah, at the very beginning it was about the volume of PPE that was required, and then about the suitability. So at the very beginning, in terms of producing, people in the high areas like ICU would be given surgical gowns which were sealed at the wrist, and you wore 2 sets of gloves and a visor. But the wards below that, it wasn't. It was a plastic apron and a fluid-resistant surgical mask, which there wasn't enough of, and it wasn't of a high enough quality. Initially, some of the aprons that were being purchased, for example, were in essence repurposed bin bags. Over time, that supply got better, both in terms of the supply chain, which was internationally purchased, and indeed in Scotland, the Scottish Government set up some manufacture in Scotland itself to produce PPE. But right through the pandemic, although over time the supply of it in terms of the amount was dealt with, the quality wasn't always dealt with. And for example, as in my statement, FFP3 masks come in a fairly standard size. Nursing's a largely female population, and many nurses complained that the FFP3 masks didn't fit properly.
I was going to come on to that, but maybe just deal with that now. I've read in a few papers that they talk about the masks not fitting properly. Can you help me? Is that because you need masks of a different size, or is that because they need fitted the same way you might fit a cycle helmet or an office chair? You might adjust it to the particular user. Is there one particular mask with adjustment, or is there different sizes?
I'm not aware of them being particularly manufactured in a range of sizes, and some of them have better adjustability than others. The issue is that the Scottish Government, through trial and error, tried to procure from different manufacturers to meet better, and everybody who was wearing an FFP3 mask was supposed to have it face fitted. So that's somebody who was qualified to, one, fit that mask for you, show you how to adjust it, and make sure that that was the supply of masks that you used going forward. Our members said that there was insufficient people trained to do that face fitting, and that sometimes when they couldn't get the mask that fitted best for them, they had to make do with what they had until such time as supplies increased.
Okay. And obviously we don't deal with that, but there's obviously, is there a skill in it insofar as, I mean, with a cycle helmet, I just use a cycle helmet as something I'm familiar with, you know, you turn it until it's tight and then you pull the straps. Is it not as straightforward as that? It needs somebody to actually show you how to fit it?
It is in essence as straightforward as that. They're usually adjusted at the back rather than at the mouth. The fact of the matter is that what somebody who's face fitting is doing is making sure that the person understands that it's crucially important that the mask completely seals around the face, whereas a surgical fluid-resistant mask is open at the side. So what they're doing is testing that when you put it on, you're adjusting it and confident in adjusting it in such a way that that seal is made.
And am I correct in understanding that these masks, the non-surgical masks, the better quality masks, if you like, were largely mass-produced for larger male faces prior to the pandemic?
Yes.
Okay. Just dealing still with PPE, you identify paragraphs 36 and 37 of your statement, you discuss the testing of PPE which had passed its expiry date. Did the Royal College have a view on essentially extending the expiry date through testing?
We raised that. The amount of PPE that was required at pace very quickly, it meant that there was difficulty in the supply chain in terms of buying it in, and there was a lot of PPE that was held in the storage areas that we have off-site for holding them that was out of date. We raised our concerns about that because people were very anxious about it. This was a novel virus that was killing people, and they were saying, well, you give me PPE, but the date on it says it's been out of date for 18 months. Is this safe to wear? But National Shared Services did batch testing of that, so what they were doing was testing whether or not, in fact, it was still sterile, for example, or still was fit for purpose. And they reassured us that they were testing all of the PPE and were convinced that the out-of-date PPE was fit for use. In those circumstances, we would have approved that being used because it was better to have that than just discard it and say it's not working.
Okay, thank you. At paragraph 38, you go on to discuss the changes in the PPE procurement system by the NSS. I think you've mentioned that, so I won't take you through that. And you also mention in paragraph 39 that community hubs were set up for the supply of PPE, and I think you briefly touched on those earlier. I just wondered, the community hubs, where were those located within a health board or a local authority area, and who was entitled to go and secure PPE from those community hubs?
I can't tell you how many of them there were, but they were in all communities, all local authority areas. So any care home environment, for example, any community providers of care, and in fact carers themselves could phone up and say, I don't have any access to PPE, and they would be given a supply of them. That became a fairly responsive thing. People could phone on the day and it would be delivered to them on the same day. So it was Scottish Government's attempt to assert their ability to buy volume and make it available to places that couldn't secure supply chain in the way that a big organisation like the NHS in Scotland could, and that was, I would have said, quite successful.
Okay, and did I pick you? You said that people that were carers, would that include unpaid carers?
Yes.
Right. And was there a fee for that? Do you know?
No.
No. Okay. You state at paragraph 40 of your statement that wearing PPE all day was uncomfortable and could be a barrier for communicating to patients. Whilst I'm sure that's correct, is there a solution to that?
There were some engineered solutions. For example, masks provided that had a see-through panel because you have people who lip read, for example. But there aren't any easy solutions to that. Wearing PPE, particularly in places like care homes, where people might have cognitive impairment, communicating with somebody when you have all of the PPE stuff on becomes much less personal. It was necessary for people, for the protection of patients and staff, but it certainly became a barrier to effective communication between nurses and patients at times, and nurses found that very distressing.
At paragraphs 42 and 43, you discussed the airborne transmission of COVID, and I think you've discussed that earlier in your evidence, so I won't go through that. In terms of, just before I move off from PPE, is it your evidence that if better testing, sorry, I'll put the question in two parts. In your opinion, would those nurses that are now suffering from long COVID, would they have been less likely to have contracted long COVID if the PPE, if there'd been something different, if you like, and I'll make it as wide as that, about the supply and adequacy of PPE at an earlier stage?
Yes, without question. And certainly the public health evidence, Public Health Scotland evidence, when they did the outbreak in hospital, when it was known that people were coming in that didn't have COVID, I saw a presentation where they were able to state in numbers, although I don't recall those numbers particularly, the number of times where patients were contracting COVID from nurses or other healthcare staff, when patients were getting it from other patients or when nurses were getting it from patients. So it was sophisticated enough in the testing that it's quite clear, and in many of those areas it was areas where they had less PPE or less adequate PPE than others. So I have absolutely no doubt that there were nurses who contracted COVID at their work who would not have contracted COVID at their work, or would have had certainly a significant less chance of contracting COVID at their work had they had higher levels of PPE.
I'll just ask you, paragraph 45, we see that your Royal College raised concerns about the higher risks of COVID to ethnic minority population, and that you say that the Scottish Government acted upon this and developed a risk assessment tool which enabled those nurses to obtain additional PPE and also work in areas where the risk of contracting COVID was lower. Can you just tell us a little bit, what was that risk assessment tool?
So initially there was international evidence that people from the BAME, black and ethnic minority staff, had less good outcomes if they got COVID, and it wasn't known why. There was no understanding of why that was the case. But acknowledging that it was, we raised that with Scottish Government because there was various courses of action that they could take. For example, make sure that all staff who fell into that category were automatically given more PPE, the higher grade of PPE if you like. They could have removed them to areas where it was known that there were no patients with COVID, which would have reduced the risk. The risk assessment process, largely people who were older had less good outcomes. So having certain conditions or being from a black and ethnic minority background the risk assessment added years to you. So if you were 30 years old and you were from an ethnic minority background, they would add X number of years, and that would increase your chance of having a less good outcome. So what it did in fact was expanded people's risk by adding years to their biological age, and said they would automatically be at more risk, and therefore we will take these actions, either give them additional PPE or remove them from working with COVID patients. As it turns out, in the end, I believe the evidence showed that the reason that people from black and minority ethnic backgrounds had worse outcomes was largely because quite often they had more long-term conditions than others. It wasn't anything to do with their ethnicity, it was the fact that they were predisposed because they had other physical reasons why they were more likely to be unwell.
Okay, thank you. You also speak positively about the Scottish Government acting quickly in relation to shielding at paragraph 46 of your statement, and you say that the Scottish Government acted immediately and helpfully to assist nursing staff who are required to shield and ensure that they were not exposed to any financial detriment. It appears to me, and correct me if I'm wrong from reading your statement, that there seems to be in areas where the Scottish Government were acting swiftly and appropriately, and then other areas like PPE which you've identified that they weren't. Can you explain why they were listening to some of your concerns but not all of them? It might be that you can't.
No. What I would say is through the Workforce Senior Leadership Group, if I was to be honest, I would make the comment that every single person that I came into contact with, either from a clinician, from a politician or from a civil servant, was trying to do the very best that they could. And the example that you give there about stuff through the Workforce Leadership Group, they did respond very quickly to things. So the shielding, for example, the health population is just like the general population. There are many people who work in health who have long-term conditions that fell into the exemption that was being done by GPs of saying to people you shouldn't go to work. They were immediately removed from the workforce, advised to stay at home, and were paid as if they were at work. So there was no financial detriment and therefore no pressure for them to continue to go to work regardless of the fact that they were at a higher level. Those things were done very well. The one area, as I have already said, where I feel that we weren't listened to, and with regret feel that we absolutely should have been listened to, was about airborne virus.
And moving forward in your statement, we have, starting at paragraph 54, the lessons to be learnt. I don't think PPE or long COVID specifically mentioned in those, and again with the benefit of hindsight, but in terms of lessons to be learnt with PPE and long COVID, is there anything that you can assist the inquiry with?
Yeah, without question. I think that obviously learning from the pandemic and the purpose of this inquiry, there is much that we did during the pandemic that had a positive impact, without question. And I think those things should just be adopted and rolled into a pandemic future plan.
What are those things? Sorry.
So things like securing supply of PPE quite quickly, identifying testing, categorising wards so that you had green pathways with patients who are known not to have, and red pathways that have, not swapping staff between clinical areas, certainly supplying everybody with the highest quality and quantity of PPE that you possibly can, are things that can certainly be learned from. Comments about patients that have been made in previous evidence about discharging people to care homes, for example. In hindsight, I would think there is learning to be done there. Without question, there will be people who were discharged from hospital who weren't tested, who imported COVID into care homes. So I would suggest that not moving people to areas without knowing their infection status, there's learning from that could be done as well.
Thank you. Mr. Provan, you've gone through my questions quicker than I'd anticipated, but before I thank you for your time today and obviously your comprehensive statement that you've provided to the inquiry, is there anything else you would like to add that you think may be of assistance to the inquiry, and in particular his Lordship and the Chair?
I think there is one area that we haven't touched on, and that's in relation to workforce. In my statement, close to the beginning of it, I point out that the NHS has a whole-time equivalent staff that's supposed to be in place to provide services to people. And at the beginning of the pandemic, there were about 6,000 nurse vacancies in the NHS alone. So although the Scottish Government did what it could to try and encourage people to rejoin the workforce, at no time during the pandemic did the NHS have the number of nurses that would have been required if there was no pandemic on. So something that commits the Scottish Government to making sure that they do have the right numbers of people would be learning, I think, that would be crucially important. And also in terms of cross-sector, places like care homes, which don't have the infrastructure of the NHS, were automatically at a disadvantage in the type of care that they were able to provide. So some collaboration between health boards in that sector would be good. And in terms of planning for the number of registered or regulated staff, doctors, nurses and AHPs, I think the Scottish Government should plan not just on the basis of the numbers of people who are required for the NHS, but in all the areas where care is provided, they should have a responsibility for making sure that we are training enough people. And there have been things that have happened in the last couple of years that have had an impact on that. So, for example, Brexit. We know that there used to be a healthy number of people that came from other European countries to work in the NHS in Scotland and other parts of the UK. From a nursing perspective, in the first year of Brexit, the number of European nurses attempting to join the UK register dropped by 95%, and we have done nothing to domestically train more people to replace that. So I think workforce planning is an area that certainly requires to be looked at quite strongly.
Okay. You told us quite a lot there, but can I just pick up on one point? You said more collaboration between care homes and hospitals. I wonder what you had in mind by what type of collaboration?
Certainly issues in relation to education of nurses in care homes, infection control assistance. So when the pandemic happened, many of these nursing homes are standalone businesses with 40 employees, 50 employees. Maybe they just don't have the infrastructure that the NHS has in terms of diagnostics, cleaning, infection control provision. So I think there could be better collaboration between health boards and the local authority in relation to the homes, care homes and nursing homes in their area, to import some of that expertise from the NHS into those environments.
That may be right. Would you accept, though, and I think we've heard evidence previously, that there's a distinct difference between hospitals and care homes? Because a care home, that's the home of the resident, and there are differences insofar as there are photos of family up and certain things that, personal belongings, which perhaps make infection control easier in a hospital. Is that a fair comment to make?
Absolutely, yeah. Hospitals are full of hard surfaces that are easy to clean. Care homes are not. And I wouldn't suggest for a moment that we should change the environment of care homes or nursing homes to look like hospitals, because it is somebody's home. But they certainly don't have the same infection control expertise, for example, that a board will have. So there is no reason why boards couldn't come to arrangements to import some of that expertise into care homes. It just didn't have the capacity to get that at short notice when they were required in the pandemic.
Thank you. That's all very helpful and interesting. I will just take this opportunity to thank you for your time, your participation in the Royal College's participation as well, and your own personal time commitment, which you've given freely. Thank you. My lord, I have no further questions for this witness.
No, thank you as well, Mr. Provan. Now, we're a good bit ahead of schedule, because that was quicker than anticipated. No offence to Mr. Dunlop, and not your fault either, Mr. Provan, obviously. I'm reasonably confident that the next witness is available because she's in court or in the tribunal hearing. I don't know if we can arrange. You're due to be heard at 1 o'clock. No, 1:30. 1:30. I imagine that if you could be heard before then, it wouldn't inconvenience you, and in fact might convenience you. Is that a fair assumption on my part? Well, can I ask someone to check when we might hear you? You may have to go and consult with Mr. Gale, because I understand Mr. Gale is going to do the questioning.
Yes.
But I'll just wait here, see if we can get a time so that everyone knows what the situation is. Thank you, Mr. Provan. Yeah, no need for you to sit there. 12? That help you? Yep. 12:30 then, ladies and gentlemen. Thank you all very much.
Thank you, Lord.